we've really created a model for how healthcare should be in our view. And that is a surround sound streaming healthcare where you have a relationship with a care team. That care team is responsible for your outcomes and they partner with you to help you live your best life.
Welcome to the Business of Healthcare podcast from the Center for Healthcare Leadership and Management. The center is based at the Naveen Jindal School of Management at the University of Texas at Dallas. The show, like the center, brings together business leaders and other forward thinkers to discuss how best to meet the challenges of a rapidly changing, increasingly complex healthcare industry. I'm your host, Dr. Bob Kaiser, Director of the Master's Program in Healthcare Leadership and Management for Professionals. We're pleased to virtually visit sunny California today. Joining us from the best breaks on the coast, San Clemente, is Dr. Scott Shreve, founder, CEO, and board member of Crossover Health. Welcome to the Business of Healthcare podcast.
Thank you very much, Bob. Really excited to be here. Appreciate all the great work that you're doing and thrilled to share our story with your audience.
Well, I understand your clinical background is in emergency medicine, but in recent years, your focus is on the technology side of healthcare. So for the benefit of our audience, give us a high-level overview of Crossover Health and also about your journey to get there. And then I want to jump into the very popular Dallas Monthly, D Magazine, where Crossover Health was reviewed with a very eye-catching article entitled, "In Dallas, an Expansion of What Healthcare Should Be."
All right. Love it. I appreciate that. Yeah, I love going back to the roots because it's so fundamental and foundational for the story. So I am an emergency medicine physician. I had the privilege to train in Arizona and to see the world from that very unique perspective. And one of the things I really saw every single day as an emergency medicine physician was about 70% of the patients I had a chance to interact with, you didn't probably need to be in the emergency room. And they were there because there was access issues, primary care was spread so thin, conditions weren't managed, there was a lot of societal ills that generated some of those visits that I thought could be intervened in a different way. And despite my best efforts every day to see those 20, 30 patients, I'd come back the next day and have the same thing just repeat over and over again. And I really felt like, wow, this really can be done different. This has to be able to be done different. And the way I perceived it was if you could really create a great primary care foundation, if you could pay those providers in a different way, if you could create an experience that people actually wanted to be a part of, I think you can do a lot of good and really remove a lot of what is kind of ending up in the emergency department. So with that Pollyannish view, I took that, I began speaking about this. I began writing about this. I began interviewing and doing consulting projects. And pretty soon after about a year and a half, 2 years of speaking, writing, and talking about this, I recognized I just wasn't going to have the impact until I did this myself. And in 2010, I just took a leap off the cliff and learned how to fly on the way down. And what we did is we opened up our very first direct primary care practice for Crossover Health. And our goal was to bring a new model, a new payment model, a new care model, and to bring that out to the world. And what was fascinating is about 2 months into this experiment, we realized, man, this is going to be a hard slog to go one by one to win these individual consumers to this model. And at the time, I was very fortunate. There was someone who was following me on Twitter. They DM'd me and they said, "Hey, I've got this little project at a company called Apple. I'd love to have you help us with." And at that time, Crossover basically pivoted from a direct to consumer to now we found this entirely new world with these employers that had gathered thousands of patients on their campuses and were looking for a new model of care. They wanted to pay for it different. They wanted it to be different. And so Crossover became the first on-site provider at Apple Computers in 2011. And that really began our journey to start to bring these types of models onto the corporate campuses of these large employers. And so we began to, after you went Apple, then of course, Facebook was interested in what we're doing. Then Microsoft, then Comcast, and then LinkedIn, and all these other companies started to come on board. And this was bringing a care model to their campuses. It was paid for directly. No insurance was involved. And then we were responsible for the engagement and the outcomes. Over the years, we began to morph. Instead of being just on campus, we began to be near campus so other self-insured employers could join. And what that allowed is now more regional employers, smaller employers could get the same benefit as the big boys on their individual campus. And then about 2 years ago, we recognized that we were never going to be able to build enough physical centers to address the needs of these populations. Our employers have populations scattered everywhere. And so we began to invest heavily in virtual care. And what we saw was an opportunity to provide in-person, online, and anytime care. We would surround the population, deliver an exceptional experience, get high engagement, manage the very basics of primary health, and then we would be accountable for some of those downstream impact and outcomes. And that's really where the model is today, where we're a full service national medical group taking care of almost 400,000 lives across the country for all these different entities that are all self-insured. We don't take a drop of insurance. We're able to deliver this service, but we are accountable for the outcomes around cost, quality, and the experience. And when you start to put all that together, we've really created a model for how healthcare should be in our view. And that is a surround sound, streaming healthcare where you have a relationship with a care team. That care team is responsible for your outcomes, and they partner with you to help you live your best life. We're going to be posting an article soon about this, Bob, where we actually talk about where we really think we are is not an on-site or near-site provider. We're really a lifestyle company. And if you think about that, what does that mean? We are really trying to help people live their best life, and their most important asset is their health. And when you don't have that asset and it's not working for you, the rest of life is very challenging. And so if you take this to the highest arc that we think it can go, Crossover is intent and aspires to become a true lifestyle company.
So, Scott, I have to ask you, what's the origin of the name Crossover? Is there any type of symbolism behind that?
Yeah. Bob, as you'll learn about us, there is always symbolism. One of our core values is design everything. So everything kind of has some meaning. And so Crossover, the term actually came from the concept of going from healthcare 1.0 to crossover into healthcare 2.0. And actually, I was a foundational member of the Health 2.0 movement way back in the day with Indu and Matthew Holt. We talked a lot about what does it mean to move to this next generation care. And the big debate we used to have, is it really all about technology and widgets and points of service, or is it fundamentally a new system? I was always the advocate for a brand new system, a way to think about it, a way to pay for it differently, a way to expect different types of outcomes. And of course, the technology is an enabler of that. But the big idea here is that healthcare can and should be delivered differently. And we can do that through different payment models, different organizational models, and different models that align the interest of the provider, the patient, and the payer. And that's really what Crossover was intended to do.
We'll get into that in a little bit more detail, but I know that you were an evangelist with Healthcare 2.0. Now that's been taken over by HIMSS. And for our audience, HIMSS is the Healthcare Information and Management Systems Society. And you're an evangelist there and actively involved in there. What you've done and what your experience is not too different than what a lot of our doctors experience in our program at the university. They're thought leaders. They're trying to basically embrace these new ideas, and they're coming up with innovative ways of making a change out from being a practicing physician into being a physician leader. And other people that we've talked to, Dr. Marty McCary, The Price We Pay, he outlines all these problems that you see. Mm. And Dr. Vivian Lee, the long fix, she talks about all these problems we have. There's a number of people there that are experiencing that, but something motivated you to go forward. So what was the biggest challenge when you made that break? And what are some of the points where you said, wow, we made it from here, now to there? Yeah. What are some of those milestones?
Sure. I think that's a great question. So first of all, shout out to Vivian Lee. So she was my dean when I went to med school at the University of Utah. So we have a little connection there, and she's done some great work, and happy to see her working at Verily now and hopefully having a big impact on a bigger stage. I get asked this a lot by physicians and, hey, how did you make the jump? How do you kind of get out of the day to day? And really for me, it was actually pretty simple. I saw the work that I was doing. It was meaningful. It was impactful in the emergency room, but I just couldn't scale it. It was 30 patients a day or whatever, and every day, and I just couldn't get bigger or broader. And so what I did is I thought a lot about going back to MBA school and so forth. And I thought instead, just like life, just like residency, you learn by doing. And at some point, you got to just commit and go. And this is really the point where most people just can't get over. They have a well-paying job. They got kids. They got mortgages. I mean, it's hard to make one of these crazy decisions to pull the ripcord and do something that you're passionate about. But what I will say is that when your back is against the wall and when it's do or die, you come up with pretty innovative ways to do things. And, there's a good example. We had this dream to start this new practice, and we opened it. And it was very successful. People loved it. They loved the model. They loved the time with the doctors. But we realized this is going to take us 20 years to build the practice. And, we need to feed our families before here and there. And so we learned to pivot. And so we had this opportunity come to us with Apple. We took full advantage of it. We delivered and executed. We found like-minded people that wanted to innovate and do something different. We found a kindred spirit in the employers. We call them health activists. And what they're doing is they're paying for healthcare and they're getting really very limited information back. They're getting no data on quality. They just pay the bill. And since these guys know how to innovate in their own industry, they're starting to say, why do I let this last part of my supply chain just hang out over here and go up 10 to 15% a year? I'm going to learn to manage this. And it just so happened that our solution mapped to how they wanted to do this. One of the things we talk to employers about is if you want to manage healthcare costs, you have got to get involved with healthcare delivery at some level. You've got to pay for it different. You got to learn to influence it. Not in a direct care way, but like organize it differently, pay for it differently, and so forth. And so with our health activist partners, we are getting to go, really, they are payers, and we think the most innovative payers and perhaps the most incented payers. They care about their employees. They want the performance that comes when people are healthy and productive and dealing with things in an appropriate way. And so we just happen to find this niche. And I think, again, my advice to any physicians thinking about this is you got to go where your passion is. And you got to be willing to take risks. There is no reward without taking some risk. And that's really hard to do. But if you can find the right path to do that, if you're passionate about it and you can go through and just walk through 1,000 doors of no till you get to the other side, that's how you win. And I think it's just that will and persistence and removing those obstacles and seeing the opportunity in the obstacles, and you will find the way. And it is so rewarding. What I always tell everyone is you look at me and you think we're a big success and done all this stuff, but this is a overnight success 10 years in the making. And those 10 years were a long walk through the desert, I'll tell you.
Okay. So when we stop and think about the pivot you made, you pivoted from direct to consumer. You also mentioned that you're bypassing the insurance. Now that sounds like a disruptor to me. And I'm kind of curious, do these state agencies that care a lot about insurance, do they consider you to be an insurer, or how do you get around that?
Yeah, it's a great question. And so it's so interesting. When we started Crossover, I actually got my insurance license because our idea was let's sell high deductible health insurance and then marry it to care. And that was a little bit of a naive thing because that starts to cross some boundaries into insurance. But what we found is that the employers get out of the insurance kind of game. They just pay for care directly. And you get into trouble when you prepay for care or there's an unlimited obligation to the payment. But if you actually keep it pretty narrow and pretty focused, pay for the services themselves, you can actually avoid a lot of the insurance issues. And so I do think the employers kind of find a pretty clear and bright line. And obviously their lawyers and ERISA attorneys and everyone else gets very comfortable with that. But we are not an insurer. We don't take full risk. We actually just get paid directly by the employer for the services we render. We don't get into the game of submitting RVUs and claims and other things. What we do is we end up our accountability. We still have to document. We still submit claims, but we don't get reimbursed for those. That's just for more documentation and a historical record. But what we are accountable for is the outcomes. That's what we get paid to do. Our employers who engage with us are expecting us that we're going to surround their population. We're going to engage a large percentage of them. We're going to reduce the cost of care because they're paying for it directly. We get about the same outcomes in about half the number of visits because, and I'll talk about that in a minute, and then we are accountable for the quality outcomes, which we can objectively show that we deliver higher quality. And then of course the scores and the metrics around patient satisfaction speak for themselves. And so that's where that accountability comes in, but it's definitely not insurance. And so we clearly avoid that.
This episode is brought to you by the Center for Healthcare Leadership and Management, the definitive resource for healthcare management education in North Texas. The center is based in the Naveen Jindal School of Management at the University of Texas at Dallas. It plays a unique role in training the next generation of healthcare leaders to meet local, regional, and national demands. The Jindal School uses its strengths in accounting, administration, finance, marketing, and information systems to educate highly qualified personnel for healthcare administration and executive leadership positions. The center is home to 7 healthcare leadership and management programs, including undergraduate and graduate programs, as well as executive programs for physicians and working professionals. For more information, visit us online at jindal.utdallas.edu/healthcare.
So is your focus entirely primary care, or do you cross over into specialty at all?
Good question. So we have a very broad view of what primary care is. In fact, we kind of rebranded it primary health. And the reason why is it's not just primary care, the physician and the nurse. It now includes mental health, physical medicine, health coaching. We have fitness in some locations. And then, of course, our care navigators are a big part of this. And so that set of services, what we call primary health, allows us to engage most of the population on one or more of those areas and then start to build a relationship with them. Clearly, we're not doing heart surgery. We're not gastroenterologists. We're not these specialists. And so we always have partnerships in the community. But what's interesting is because I have a relationship with the member and because they take 95% of my recommendations because of the trust we build up with them, which is the currency of our model, is we go out and we go into the network and we curate the specialist network. I don't go out and recontract. I'm not setting rates. I'm not doing any of that. I just take, if they're on the Aetna network, there's 10 cardiologists on the Aetna network. Because I partner with the employer, I actually get claims data. I can do my own analysis and try to figure out if I can understand is there cost or quality differences. Very challenging to do, by the way, but we can do our best there. And then, of course, we have natural referral patterns. We know who's going to get our patients in. We know who's going to get the results back. We survey our providers. We survey our patients. We see where that best experience is. We try to align that with cost or quality data if we can. And now we curate the network. So if you're a high performer based on our criteria, we're going to send patients to you. When we had 100 patients, no one cared. When we have 400,000 people care. And they're now starting to give us, our patients will get, great service. They'll get great access. We get the data back. So it's this kind of full loop care, which is where our care navigators really help us to augment that record. But that's an important part of the care model. But to answer your question directly, we have an expanded view of primary health. And then we partner with the secondary care providers, the specialists, the hospitals, the diagnostic centers, and so forth.
Well, that brings up a very important topic here, and that's data. You mentioned data, analytics, taking care of a large group, 400,000. You have to be able to engage in analytics and things of that nature. And that's one of your strong cards, right?
Yeah, it's interesting. As I think about American medicine, it is just shocking how blind we fly. Right? I see patients really, if I'm a doctor in a traditional busy practice, I am the slave to the schedule. Whatever shows up on the schedule, that's all I can keep up with that day. I'm just doing whatever shows up. I really don't have time to be proactive and figure out, well, who should be on my schedule instead of just serving those who come in. So a lot of, individual primary care providers, smaller groups, they really struggle because these require investments. They require some level of scale. But let me tell you how it can be different when you kind of can get there. So in our case, we already have full claims data on all of our members. We have our members' permission to peruse that data and to proactively reach out to them to close down social determinants of health, any screenings or proactive care gaps that might exist. And of course, anyone with conditions we can track. So what we've developed is a model that tracks over 40 different clinical metrics. They're all the things you would expect to see, the HEDIS measures and so forth. But I can tell you as our member exactly where you stand on that and what I can do to close any open gaps that exist. And that's just a baseline kind of care model that's now proactive. And so our providers aren't just waiting to see who shows up on the schedule. They practice in care teams, and they actually know of my panel of 2,500 patients, who needs to see me today? How are my 32 diabetics doing? Where are my 47 asthmatics? Do they all have the things that they need? And it's not just the doctor worrying about that. The whole care team worries about that, and they can see that data. So when someone comes in for physical therapy, they might have totally unrelated gaps in care that our therapist has a chance to engage with them on. The host who checks you in can see exactly where you're at. And so everyone on the team is working together, again, with the patient's permission. This isn't like Big Brother telling you, hey, Bob, you got something, let's take care of it. It's someone that you know and trust that's built a relationship with you and is helping you kind of live your best life. And that's where this data is really powerful. So we put all of our data into an enterprise data warehouse. That enterprise data warehouse spits out clinical insights. And again, the insurance company has been doing that for decades. The problem they have is they don't have any way to contact the member that's efficient. They have no relationship and no one can follow up on it. In our case, those insights go directly to our care team. That whole care team is responsible for working those down and closing those out. And then, of course, we're connected to our members through proprietary technology that we develop that I can serve up those insights so that you as a member could just go ahead and close those out on your own or engage with the care team as needed. And to us, that is what healthcare should be. I want a team for my own family. I would like a team that is watching and monitoring and helping my family be as healthy as they can, steering us when we need higher level care, and just taking care of the basics when I need there, and great access. That is what we're building.
Well, you like to feel that you're building trust in a primary care relationship, and that trust will carry you further. Let's move this up to a higher level. Let's suppose that I work for Amazon and I'm getting these services from you, but I also have a history of information at one of the health systems in town. We have 3 or 4 nice big health systems in town. How willing would these health systems be to share data with you? Most of these have their ACO and they're trying to protect it. And they're really trying to keep their patients there and not have them leak off to somewhere else. Is that a difficulty that you have to confront?
It's a great question. I just look at reference points. Now, one of the things I wanted to mention earlier when you're talking about all the different physician leaders and innovators that you meet with is I love being in healthcare because we're 5 to 7, maybe 10 years behind other industries. And you can just see how things are going to evolve. I feel like I can see the future.
Yeah.
When I look at financial services industry, very sensitive data, very private, needs to be secure. These guys have figured out the data liquidity issue. It's just the data flows. I have all kinds of apps. I'm logging in. I can use all these services in combination. My question is what the heck is wrong with the healthcare industry? Why can't we get somewhere closer where that information sharing happens more seamlessly? I like a lot of the efforts that we see with HIEs and interoperability, but they just seem to be so slow, so intermittent, and so challenging. So the situation you described is a challenging one that we have to face. At the end of the day, I think we have to acknowledge that the interface of healthcare is the fax machine. And it's embarrassing that that's the case. But what ends up happening a lot of times, we end up going and having our care navigators have to manually chase this stuff down to get these reports back and forth. Now, there are situations where healthcares have really advanced, where they got great systems, they got Epic in place, they're a part of an HIE, and that data flows much better. And so I think we're going to see this evolution. It just can't be so siloed anymore, and we need to work together. We are developing those partnerships in some of the areas where we have the most concentration in the Bay Area. We've got great partnership with some of the big systems in place where we can tap in and extract data kind of on a one-off basis. But it's definitely not a continuous flow of information like I would hope for, nor expect in 2021. Now, I do think a lot of smart people are working on that, and I hope to see that improve. But right now, it's still kind of a manual process, to be candid with you.
Well, these HIEs, these health information exchanges, let's look at this at a little bit higher level. I'm curious to think I would have hoped that the government would have had a federated system which basically all this data could be shared and things like that. And where it all comes into one spot. And maybe somehow there'd be a disruptor, an innovator, whether it be one of your customers like Apple or Google or Amazon. There's been a few attempts of that, right, with Haven and things of that nature. But I would like to think that there ought to be able to come up here in Dallas alone. You've got the big electronic medical records, Epic and Cerner. And I bet you there's another 50 smaller EMRs, electronic medical records here in town. And none of these are being tied together. So do you see that in the future? Yeah,
it's a massive problem. And I think it goes to more of a philosophical question around centralization versus decentralization, right? So the Apples, the Facebooks, Amazons, all these huge network companies have some huge advantages because they're centralized. They can make these investments and people kind of trust them with their data. And then I think you're starting to see more people who start to really question that centralization, and should there be a more decentralized approach where maybe I can't just get shut off of social media, or I can't just get blocked from X, Y, or Z. So what I like to think of is, as you think about this, you're right. Should there be a government standard? Should there be somewhere where all this data is warehoused? Or is another approach a decentralized approach? And this is where I go back to crossover as a lifestyle company. What I mean by that is, if it was me, I don't know that I love trusting the government with just all my information. Like, what about if I had a third party that was really trusted and they based their business on trust, and I could really go with them and they could store my records, and I would have a choice between those. If I don't like the services of this one, I can move to that one. What I think the future will be is that there will be healthcare memberships that you join an entity that is trusted, that serves you well, that provides care, that provides these other services. One of those services needs to be the maintenance of your health record that you have access to. I think it'll be maybe a decentralized kind of play, so it's not just one of the big aggregators. But I'd love to see a world like that. And let me tell you where this is going to come to a head very quickly. I think this whole thing around the vaccine and so forth is really fascinating to watch kind of COVID play out. And now the vaccines starting to have an impact. Here's my question. Have you seen how these vaccine records are being done? It is unbelievable, man. You're getting a paper record written in pen, and that's your vaccine record. So here's my question. Who's your healthcare notary? Who's going to get that into an electronic format that is going to sign off that, yeah, this is legit and this person really had this? And beyond the vaccine, we're at a stage now where no one cares about the vaccine. What they care about is proof of immunity. So who's going to now be the holder of your record so that you could show that record when you want to go to a movie, a concert, you want to travel, whatever. And what I keep thinking is I believe there's going to be a model where people join an entity that is managing and helping them with their health that will actually maintain their records and is trusted to do that and can serve up and can notarize health information, because I think it's going to be used that way in the future. Now, I don't know what I think about that. I don't know if I like that, but I do think you can start to see a world where, man, it might be important to be a part of something that is your health partner and that can provide and certify that data with you.
Yes, I just got my second vaccine, and I got that little piece of paper. It's smaller than a credit card. And I can make copies of it and sell it to people, I guess.
Yes, these kind of big, large societal upheavals have lots of good and bad actors. And that goes to my point. Wouldn't it be great if you had your app with your trusted partner that everyone knew, oh yeah, that's a validator and authenticator of this information. And I really think the medical group should be that trusted ally to help you do that, not necessarily the government. So that's just a point of view. But, I think all these efforts need to be undertaken simultaneously. We can experiment to see where those go.
So a couple more things I want to touch base with, Scott, before we terminate here. One, obviously, is the Amazon story in Dallas. And I think people need to hear that story and how it's working, how it's going to work in the future. But also others who are trying to do similar type things, maybe not exactly the same way you are. People like, or organizations like Walmart, and they have their health clinics now. They're addressing primary care. And other people like CVS with their health hubs. Do you see you working in a cooperative way with them? Or do you look at them, even though they're trying to solve similar problems, as competition or co-opetition?
Here's what I learned a long time ago with my experience in open source is at the end of the day, the healthcare issue is a $4 trillion problem. We need every innovator we can to come help solve this problem. And these huge companies with all their assets and resources certainly should be a part of that. I view our role as that nimble, quick disruptor that can demonstrate and show value quickly, can move quickly, can adjust. And at some point, you can see how these paths would cross where we'd actually leverage some of the network of some of the, a CVS or a Walgreens or these others that are building out, the retail players definitely have a role to play in healthcare. And so I'd love to see where that kind of goes over time. And I view our job as like, again, in a $4 trillion problem, there's a lot of room to play, a lot of room to experiment. We're going to stay pretty focused on our business, which is the self-insured employer, helping these health activists think about how they can add value to the experience of the employees, how they can drive down costs, and how they can achieve these great outcomes. And it really kind of might tie back to the story of Amazon. Everyone is so interested in what Amazon is going to do in healthcare and so forth. And I don't have any more insight than the next guy. But the one thing that we do know is we've had the privilege to work with the operations team. And this is the group that is in the warehouses. These are the essential workers, the drivers, and everyone else who's just making the economy work during this time. And they have a real issue, right? They have people that are essential workers. They need to show up. They're in physically contained places, and they need their people productive and healthy and working. And so what Amazon decided to do is like, hey, we know how to do all this other stuff, but we don't have doctors and nurses, and we'd love to have primary care. They really believe in primary care as the foundation of a great healthcare system. They were concerned about access. They were concerned about quality. And so what they decided to do is, let's pick Dallas since we're talking about that. Dallas has about 50,000 Amazon employees. They're scattered in all kinds of different parts of the city, and they're scattered around the warehouses. But, they don't all live where the warehouses are. So Amazon took a different approach. They said, we want you to surround the entire population with virtual health. Let's start with that. Secondly, we're going to strategically come back in and build physical centers, not on or near the campuses we are, but in the neighborhoods where they live. And in fact, they're called neighborhood health centers. What's interesting about these is that these are a smaller footprint and they're more focused, because I do a lot of the initial work online. People call, if we can take care of everything online, we'll do that. They're online messaging back and forth. And if we can solve the problem, we're done. If not, we've done a lot to diagnose it and to triage it. And so now when someone shows up, it's more of a confirmation visit as opposed to an exploratory visit. And that really narrows what I need to have. I need the blood draws. I need the vaccinations. I might need to lay hands on you to properly diagnose or care for a condition. And that's what these centers now become. So I've got 50,000 people plus their dependents. I've got 5 locations in this tight geography. And now I've created a network and I have nodes on the network. And now I can start to become accountable to that group of patients. And I can tell you, we used to get a little bit of a hard time when we first started. Oh, you guys are taking care of Apple and Facebook and Microsoft, all the tech elite. Well, let me tell you something. The warehouse workers in Texas, they're not a part of that group. They have real deal issues. They have health concerns. Some of them haven't had health insurance. And so we're dealing with all the things that you'd expect. And it's been fantastic. These are people that might not have had healthcare. Amazon has such a rich benefit and such a valuable service to give people benefits on day one. And they really care about their employees. And they're saying it not with their words, but in the statement, we're going to do this in 5 regions. And if this goes well, we're doing it to the next 15. And at that point, you'll go from 150,000 lives that we're covering to 800,000 lives. And now we start to have the impact we talked about. We start to have a care model that's paid for directly, that surrounds the member, that streams to them, that is a trusted relationship over time and is accountable for the outcomes. And now we're starting to get to some scale that actually can have the impact that we dreamed about 10 years ago.
Well, it sounds to me like everything you just described can be summarized in one word: value. And employers expect value. And that's the only thing that matters to them. If they're not getting value, you don't belong with them. And I think you're finding that out.
Absolutely. Listen, these guys are no joke. I mean, like all these clients we work with, they have incredibly high expectations. They expect a lot from the reporting and from the quality and the experience, and they're demanding, and they should be. They're paying for it. And so you're exactly right. Value is actually, the book I read was Redefining Healthcare, right? That was the initial inciting book that I read. And it talks all about what outcome do you get for the cost you're paying? And that is the formula for value. So if I can deliver these exceptional outcomes and I can do it for a lower cost, I've got 2 levers working simultaneously, synergistically to get this to the value. And that's what they expect. They expect it from every part of their supply chain, and they're kind of done with their healthcare supply chain not delivering value.
Well, I know there's a book in you somewhere. I'll look forward to it coming out here, Dr. Scott Shreve. I got to tell you, this has been a treat for us to be able to have time with you. I can sense your passion, your interest, your desire, your work ethic. And I'm so delighted that we could capture some of this for our audience on the Business of Healthcare podcast. And we will revisit with you again in the future. We look forward to catching up with you and trend as you keep this momentum going forward in the healthcare space. So thank you again for your time today.
We really appreciate it, Bob. Thanks for all your work and sharing some of these stories. It's an inspiration to all of us who have the privilege to watch. So thank you.
Thanks for listening to the Business of Healthcare podcast. Join us online at businessofhealthcarepodcast.com to find episode links, notes, and more. Be sure to subscribe to the Business of Healthcare podcast on Apple Podcasts or your favorite podcasting app. To learn more about the Center for Healthcare Leadership and Management, go to jundal.utdallas.edu and then search under the Center and Institutes tab on the navigation menu. Also, we want to hear from you. If you'd like to provide feedback, make suggestions for future guests or show topics, or just want to get in touch with us, email us at healthcarebizpodcast@utdallas.edu. Biz is spelled B-I-Z. And let us know how we're doing. I'm your host, Dr. Bob Kaiser, with the Center for Healthcare Leadership and Management, where we're leading change by changing how we lead.